So good evening, everyone. Like I said, we're going to start just immediately. All right, can everybody hear me? Can you confirm you can hear me?
Yes.
Can you see my slides too?
Yes, sir.
Okay, great. So today we'll be looking at very important topic, practice as an anesthetist. We'll be looking at the Neuraxial block or Neuraxial Anesthesia. And we're going to be following this learning outcomes. So at the end of this tutorial, you should be able to describe the anatomy relevant to neuraxial blocks. All right, explain the pharmacology of local anesthetics and adjuvant used in neuraxial anesthesia, differentiate between spinal epidural, combined spinal epidural, and Caudal techniques, be able to identify indications, contraindications, and complications of neuraxial blocks, and you should be able to demonstrate the technical steps of neuraxial anesthesia, all right, and apply neuraxial block effectively in various clinical scenarios. So follow this outline, all right, as we can see. So before we continue, we have some case-based MCQs. Okay, so quickly, like I said, I have about 99 slides, so I want us to see how far we can go today. So the first question is, a 70-year-old woman undergoing total hip replacement under spinal anesthesia begins to complain of nausea and lightheadedness shortly after the block is performed. On examination, her BP is 80/50 millimeters of mercury. Heart rate is 48 beats per minute. Sensory level is at T1. So what is the most likely cause of a bradycardia? Anybody? Anybody quickly?
A. High spinal anesthesia involving the cardioaccelerator fibers.
Okay, I
The
didn't
answer is A.
A. Okay, correct. A. All right, so where am I? Can you see my screen? Like, okay, number 2, correct. The answer is high spinal involving cardioaccelerator fibers. Okay. Number 2, a 15 kg child is scheduled for circumcision under Caudal block. What is the maximum volume of 0.25% bupivacaine for a low sacral block in this child if you are using the Armitage regimen? Quickly. Anyone? Anybody?
A, 0.5 mils per kg.
Okay, Shola A. Okay. A is correct. I hope we know how to get A. We'll see other answers as we go on. Where's my slide? I can't see my slide. Can you still see my slide?
Yes, we are seeing them.
Okay, so number 3 question. A 32-year-old woman undergoing perianal surgery is given spinal anesthesia with 2.5 ml of hyperbaric bupivacaine. She's kept sitting for 5 minutes before lying down. What kind of block is this likely to result in?
Saddle block.
You're breaking.
Saddle block.
I can't hear you.
Saddle block.
Okay. Saddle block. Who is that? Please, can I get your name? Saddle block, correct.
Friday Chitonga.
Okay, correct. Saddle block. During labor, an epidural catheter is placed and the anesthetist ingests 3 ml of lidocaine with adrenaline, 1 in 200,000 as a test dose. Which of the following indicates intravascular placement?
C.
Who is
C.
that?
Diana.
Sorry?
Dr. Diana.
Dr. Diana from Kenya.
Kenya. Yes.
Okay, correct. Increase in heart rate by more than 20 beats per minute. Correct. Okay, so the last MCQ. After spinal anesthesia for C-section, a patient becomes apneic and not responsive. Our pupils are reactive and blood pressure is undetectable. What is the most appropriate interpretation of this event?
B, total spinal.
That is total spinal.
Okay, who answered that? Can I get your name? Who answered? Huh?
Lilian.
Lilian from Kigali, Rwanda. Okay. Now, these are possible likely exam short answer questions. Okay, for 10 marks each. I think how many of us attempted the questions I sent earlier on? So these are likely questions and we're going to get the answers to them as we go on today. Okay, so this is an OSCE case. All right, so you have a 28-year-old primary graviga term presenting for elective cesarean session, and you are asked to perform spinal anesthesia. So the task, explain the procedure to the patient. Okay. Describe the steps of the technique. Discuss possible complications and how to manage them. Right, that's the first OSCE exam. The second one is a 30-year-old woman in active labor requests pain relief. You are asked to insert an epidural catheter. So your task will be obtain an informed consent. How will you do that? And you have to perform the procedure and you demonstrate how you're going to administer third dose and interpretation. Number 3, a 32-year-old woman presents with severe headache 24 hours after receiving spinal anesthesia. So your task, take a focus history, describe the diagnosis, and explain the management. Okay? And the fourth one is 65-year-old male patient undergoing TURP under spinal anesthesia becomes hypotensive and apneic. So what's your diagnosis? Outline immediate management steps and explain preventive strategies. Okay, and I hope at the end we'll be able to answer these questions confidently. A 5-year-old child is posted for hernia repair. You are asked to perform a Caudal block. So you are asked to identify relevant anatomical landmarks. You are asked to describe the technique and explain how you will determine the appropriate dose. How many of us are confident to answer these questions? Are we confident to answer these questions? Okay, I hope we are. So we'll find out as we continue. Don't know why my slide keeps running away. What's happening today? Can you see my slide? I can't see it.
Yes.
What's happening? I can't find my slide. Oof. Okay, can you see it now? I think I can see it now. Okay, so let's start the lecture. All right, we know that neuraxial anesthesia comprises of refers to 3 types: spinal anesthesia, which could be a single shot; epidural anesthesia, which could be single shot and continuous infusion through a catheter. We can have combined spinal and epidural. All right, we combines the two. Caudal block is under epidural anesthesia, so that's where It's not under here. Okay, you know that the neurologist, James Lino-Coney, was the first to perform accidental epidural injection into a dog. All right, August Beer was the first person to successfully use spinal anesthesia with cocaine. And in the early 20th century, we have different advancement in spinal needle design. Okay. So let's just remind ourselves about the anatomy of the neuraxial space. This comprises of the vertebral column, the spinal cord, and the meninges, the epidural space and its content, and the dermatomes and their relevance. Just a way to remind us, we have 33 vertebrae, 7 cervical, 12 thoracic, 5 lumbar, 5 sacral, and 4 corsage vertebrae. And this is important, especially when we're talking about caudal block as we go on. Okay. The spinal cord terminates at L1, L2 in adults, and in neonates L3. Okay, so the epidural space lies between the dura mater and the ligamentum flavum. Contains fat, lymphatics, blood vessels, and nerve roots. And the dermatomes we are familiar with. So this is just a diagram of the anatomy of the neuraxial space. So the spinal cord, we need to just remind ourselves of the anatomy of the spinal cord, which extends approximately to L1, L2 vertebral level in adults, and neonates about, L3 vertebra. So it has 3 parts: the conus medullaris, which is the taper end of the spinal cord, a bundle of nerve roots, which extends from the conus medullaris, extends to the lower limbs and pelvic organs, which is the caudal equina. And sometimes we have injuries to it where we have the caudal equina syndrome. We have phylum terminale, which is the fibrous extension of the pia mater, and which anchors the spinal cord of the coccyx, preventing its excessive movement within the canal. All right, the spinal cord is supplied by a single arterial spinal artery, which supplies about the 2/3 anterior part of the spinal cord, while the PH posterior spinal artery supply the posterior 1/3. We have other arteries, including the radicular segmental arteries, the artery arterioquens, which supplies the lower spinal cord. Okay, so layers of anatomy of spinal anesthesia. If you're starting from posterior to anterior, since you're going to do your spinal from the back. So we have the skin, transversing the skin, subcutaneous fibers, supraspinous, interspinous ligament. We have the ligamentum flavum before the dura mater. And once you pierce the dura mater, you enter the subdural space, arachnoid, and the subarachnoid space. So important for us to remind ourselves of the physiological effects of neuraxial anesthesia. All right, on the CVS, sympathetic blood causes vasodilatation, which primarily affects the venous capacitance vessels, and this is what accounts for the hypotension, all right, of spinal anesthesia. It leads to venous pooling, reduced preload, and hypotension. Like in what we saw in our MCQ, if the blood reaches to T1, T4, it affects the cardioaccelerator fibers with bradycardia occurring. This is due to the unopposed vagal tone. All right. A lot of times, the compensatory tachycardia resulting from hypotension may be blunted, especially in patients with high spinal. So intercostal muscle paralysis may occur only with high thoracic blocks, but remember that the informative function, which takes its nerve supply from C3 to C5, is totally preserved. Okay, we may have decreased functional residual capacity and curve efficacy in adults, elderly patients, and those with underlying lung disease with increased risk of atelectasis. In the GI system, we have the unopposed parasympathetic activity leads to increased peristalsis, and secretions, which may result in nausea and vomiting and abdominal cramps. All right. The sparkling vasodilatation from sympathetic block can reduce blood pressure further. Okay. Enhanced gear motility may be useful, especially as it helps in post-operative bowel recovery. The genitourinary system urinary retention is common due to blockage of H2, S4 nerves that supply the bladder. Neuraxial block can relax the bladder that through some muscle and reduce the urge to void. And this is why we usually catheterize our patients that we're given spinal for, apart from monitoring urine outputs, because of the blockage of the destructive muscle, and there's reduced urge to void. Endocrine metabolic effects of neuraxial anesthesia. All right, the neuraxial anesthesia can block the surgical stress response, reducing catecholamine, cortisol, and glucose levels. And this is usually beneficial in patients who are diabetic cardiac patients and patients with immunocompromised status. All right, improved glycemic control, reduced post-operative insulin resistance have also been noted, so which makes spinal very good for patients with diabetes. Okay. Neurological effects, intentional motor and sensory blockage allows for surgery without general anesthesia. If excessive rostral spread occurs, there's risk of total spinal, which can lead to loss of consciousness, apnea, and hypotension. So all of these effects accumulate in the advantages of neuraxial blocks, decreases stress response to surgery, reduces the incidence of venous thromboembolic events, decreases post-operative mortality and morbidity, reduces hypercoagulable state associated with surgery, therefore improving blood flow, decreases bleeding and transfusion requirement, the fund to reduce hospital length of stay, increases early return of GI function following surgery, and last but not the least, it helps to reduce opioid requirement for post-operative pain relief. All right, these are some of the indications. Let's go to contraindications. By now, I like mnemonics, so champions. All right, so we have champions as our mnemonics for contraindications to neuraxial block: C, coagulopathy; H, hypovolemia; aortic and mitral stenosis, these are fixed cardiac output state; P is patient refusal; I, intracranial hypertension; O, all right, there are others, including uncooperative patient, neurological deficits, and sepsis. This can be broken down into both absolute and relative contraindications. So you must know that, okay, as we consider neuraxial block for our patients. Complications, hunch beast, all right, hypertension, urinary retention. We have neurological sequelae, like chidonitis, meningitis, Caudal equine syndrome, like mentioned before. You can have cardiovascular collapse from high or total spinal. We have hearing impairment, or a headache, posterior puncture headache. You can have backache from direct needle trauma, itching, and shivering. So this makes the mnemonic hunch beast. Okay, so how do we assess for the level of block? We can do 3 different assessments. The first one is the sensory block assessment using the cold sensation test. All right, remember that it disappears at higher level than touch and pain. So you can have cold sensation maybe at T10, all right, but pain maybe at T8. Okay, and we have the pinprick test, which uses a blunt needle or a sharp object. And this assesses small myelinated fibers. All right. Then we can have the light touch test, which uses a cotton wool or gauze. All right, which assesses large myelinated A, beta fibers. Now, if light touch is absent, that means the block is deep. Most of the times we may do with pinprick or cold sensation test. But if light touch is absent, all right, the block is deep. Then we have the motor block assessment, which uses the modified Bromage scale. Okay, especially for epidural. All right, so Bromley score is 0 when there's full movement of the lower limbs. That means there's no block at all. If the patient has a Bromley score of 1, unable to raise extended leg but can bend the knees, which is partial block. If the patient is unable to bend the knees but can move the feet, all right, Bromley scale 2. But if he's unable to move both feet and knees, there's a complete block, and you give the Bromley score 3. Okay. Autonomic blocks assessment, all right, we can use both the temperature test of degree of hypotension or the parasympathetic effect by spinal anesthesia higher thoracic levels, which can cause bradycardia. All right, so 3 levels of assessment: the sensory, motor, and the autonomic block assessment. Okay, so let's dive into spinal or subarachnoid block. We know this already. All right, so equipment for spinal anesthesia. All right, we have different types, and they're classified into cutting and not cutting, or cutting and pencil point. So the cutting, the Quinque spinal needle, all right, usually has a sharp cutting tip with a hole at the end of the needle. So this is a Quinque spinal needle. Then we have the Winter-K and Sprotted needles. These are pencil point or not cutting. All right, they have a closed tip shaped like a pencil with a hole on the side of the needle. All right, the importance or the advantage of the pencil point or non-cutting is that they are designed to minimize leak of CSF after dural puncture, and therefore also reduces the risk of dural puncture headache. So how do we follow step by step? All right, use spinal. Okay, as you want to select the appropriate patient vis-a-vis indications and contraindications. You want to position the patient seated with feet on a stool. We're going to come to that as we go on. Identify appropriate intervertebral space using the intercristine, or also known as Tophius line. The intercristine or Tophius line crosses the body of the 4th lumbar vertebra on the interspace between the 3rd and 4th lumbar vertebra. Okay, needle insertion into the identified space to the subarachnoid space, and know that the correct placement is confirmed with a free flow of CSF, where after that you deposit the appropriate volume of local anesthetic agent. You may also add adjuvants such as opioid as needed. Else, you lie the patient back to the supine position with a pillow behind the head. I remember a consultant used to tell us, you must put a pillow, all right? Why? To prevent excessive rostral spread, the local anesthetic agent. And the question we asked before, how can you prevent, total spinal or high spinal? So you want to put a pillow behind the head to prevent excessive rostral spread. Okay, so there are some factors that affect the level of spinal block or even epidural block. So number 1 is the site of injection. The vertebral level at which the local anesthetic is injected affects the spread. So injection at higher levels results in faster capillary spread due to proximity to thoracic curve, while injection at the lower levels may limit upward spread due to gravitational effect. The positioning of the patient. Okay, all right. Both immediately before and after injection plays significant role in the spread of the LA. Patient is sitting position, the local anesthetic agent pulls in the lower lumbar and sacral region due to gravity, resulting in a lower level block, all right? And if you ask the patient to sit for 2 to 5 minutes, you have a saddle block, all right, which is useful for perineal and lower limb surgeries. Reverse in the lobar position encourages caudal spread, resulting in lower block level. and this is usually used to prevent excessive cavalry spread in high-risk patients. Age is another factor that affects the level of blood. Elderly patients have reduced CSF volume and with increased dural permeability leading to higher spread of your local anesthetic agent. So for elderly patients, you want to use lower doses. All right, young adults and children have higher CSF volume and faster circulation, which can result in an unpredictable spread. Patients' characteristics like height and weight, extremes of height, the very short and the very tall, can influence the distribution of your local anesthetic agent. So patients who are tall may require slightly higher doses of your local anesthetic agent. Obese patient, epidural fat compresses the CSF space, which leads to higher spinal block for the same dose. All right, this also results from venous engorgement in the epidural space, which also reduces the CSF volume, enhancing cavalry spread. So obese patients may experience exaggerated spread, and this requires dose adjustments in this group of patients. Another factor that affects the level of block is the use of additives. Your epinephrine or phenylephrine, they reduce absorption of local anesthetic agent, which prolongs the block. They enhance density of anesthesia, minimize systemic toxicity by delaying the peak plasma concentration, and therefore also reduces the incidence of hypotension. All right, opioids like fentanyl, morphine, and sulfentanyl enhances analgesia. Okay. I'm trying to mute this person. Okay, can you mute your mic? I can't seem to do that here. All right. I guess we can't stop this from happening, but I can't even see my screen anymore.
I think some of us can still see the screen. Okay, it's gone off.
Okay, I think it's back now. Can you see now?
Yes, sir.
Yes, you can see.
Yes, sir.
Okay, so we've talked about the use of additives. Clonidine or desmetomidine, these are two alpha agonists, and they enhance and prolong block duration. All right, sedative and analgesic effect also reduce the need for systemic opioids. So gravity, talking about hyperbaric solution, all right, these are denser than CSF and they follow gravity. Okay, so higher block if you have a head down teeth, and the head up will lead to lower block. For hyperbaric solution, they rise opposite to gravity. So this is usually used for unilateral spinal for probe position surgeries. Isobaric distribute evenly and may reduce and may lead to more predictable block levels. The dose of the local anesthetic agent also plays a role in the level of block. Higher doses will lead to higher block levels, and vis-a-vis, the requirement for you to know the dose you are going to give vis-a-vis the level of block you want to achieve. Excessive doses can lead to high spinal or total spinal. The pH and baricity of the local anesthetic agent, all right, we've talked about gravity and baricity, and pH also influences onset time. For instance, adding sodium bicarbonate to the local anesthetic agent can speed up the onset. You remember we talked about all this when we were talking about local anesthetic agents in previous lectures. About age, I don't know how many of us still do it. I remember it was discouraged, but the idea was to achieve more uniform drug distribution, all right, potentially reducing unpredictable blood heights. How do you do that? You aspirate and re-ingest CSF multiple times during spinal anesthesia, and it is thought to enhance the mixing of local anesthetic agents with CSF. Okay, so all of this can be grouped into a mnemonic spinal. So S, site of injection, P, positioning immediately and after the block, individual patient factors like age, height, obesity, N is the dose of local anesthetic agent, A, additives, and L, the properties of the local anesthetic agent itself. So these are some of the mnemonics for you to remember the factors that affect the level of spinal block. Okay, so positioning, how do you position a patient for spinal? All right, we have the sitting, which is the commonest, all right? And in the normal sitting position, the patient sits on the operating table with both feet placed on the stool and both hips and knees flexed maximally. Let me repeat this. The patient sits on the table, both feet are placed on the stool with the hips and the knees flexed maximally. We have the modified sitting position in which the patient sits up from the supine position, but the legs are still remaining on the operating table. The knees are maximally extended, or the hips and knees are maximally flexed. It depends. Okay. So when the patient is sitting on the table with the legs on the table, operating table, it's not the classical sitting position, it's the modified sitting position. We have the lateral decupitous position in which the patient flexes the back, the knees, and the abdomen. So an assistant usually helps to hold and encourage the patient in position, but the patient usually lies parallel to the edge of the bed closest to the anesthetist. Spinal anesthesia may be done in prone position. I don't know how many of us has done that. All right, may be used for surgery such as rectal, perianal, and lumbar procedures. Usually an hypobaric or isobaric solution is preferred to avoid rostral spread and decrease the risk of hernia or the spinal. All right, so this is just the position we're talking about. Okay, so the first one, the patient is here, all right, and sitting with the feet on the stool, with the hips flexed and the knees. And this other one, the patient is like sitting from the supine position with the legs on the table flexed, extended, fully extended. And we have the lateral decupitous. The patient's back is closest to the bed, to the anesthetist, okay? And sometimes you see the heels are vertical, all right, while the knees are drawn up to the chest. This is to create the maximal opening of your intervertebral spaces, okay? Now, a saddle block is a type of low spinal, all right, that suggests sacral nerve roots, providing anesthesia and analgesia to the perineum, buttocks, inner thighs, and lower sacral dermatomes. All right, oftentimes I tell my residents, this patient is going for a perineal surgery. Why do you want to give spinal? Do a saddle block. How do you do it? You give your low dose spinal. Okay, let's go to the technique. You give a small dose, all right, 0.5 to 1.5 ml of 0.5% per is injected at the appropriate intervertebral space, and then you ask the patient to remain seated for a few minutes, which allows the drop to settle down in the lower sacral region due to gravity. All right, the advantage is that it avoids unnecessary motor block of the lower limbs. It causes less hemodynamic instability because it spares the sympathetic chain. Therefore, there's reduced risk of hypotension compared to full spinal anesthesia. And it leads to quick onset and recovery, all right, because of the level of block that is achieved. And this leads to early ambulation and recovery. All right, so a lot of times many people confuse high and total spinal. All right, so there are 4 features or 5 features that differentiate high and total spinal. So the level of block, high spinal is between T4 and C3, while total spinal, the earlier spread to the brainstem. All right, you have symptoms like hypotension, bradycardia, dyspnea, difficulty with speaking. All right, while for total spinal, there may be loss of consciousness, respiratory arrest, and dilated pupils. Okay, they may be mild to moderate cranial nerve blockage for high spinal, but there's severe respiratory involvement because of the brainstem involvement in this patient. In high spinal, most of the time, patient may remain conscious, while in total spinal, the patient consciousness may be lost. So management also is tailored to the symptoms. Oxygen, fluid, and vasopressor may all that will be required for patient with high spinal. While for patient with total spinal, you may need to take over the airway and send the patient to ICU for full ICU care. Okay, so these are case-based scenario for spinal. Okay, so a 30-year-old patient receives spinal anesthesia for an elective cesarean section with 10 milligrams of bupivacaine plus fentanyl. So what are the indices for adequate block for surgery? All right, from your block assessment. The second one is a 60-year-old male patient undergoing transurethral resection of the prostate under spinal anesthesia, who suddenly develops dyspnea and hypotension. The assessment of blood level reveals co-sensation loss extends to C8, and the Bromage score is 3. So what is your diagnosis? And how will you manage this patient? These are for your consumption. All right, I like this one. A 70-year-old patient, height 170 cm, weight 75, with your osteoarthritis of the hip, is scheduled for elective total hip replacement under spinal anesthesia. He has hypertension, well-controlled diabetes, and there are no indications to regional anesthesia. So you prepare a 3 ml of 0.5% azobarate bupivacaine, and you administer the spinal at L3L4 using a Millian approach, okay, with the patient posterior and the lateral decubitus position. After 5 minutes, the sensory level has been tested and the block is found to be uneven with a hair spread on the dependent side, T6 on the left and T10 on the right. So why do you think this block is uneven? What could you have done to ensure a more predictable block? How can isobaric bupivacaine be made hyperbaric in this case? Okay, I wish we can talk about it, but our time is fast spent. But think about some of these case-based scenarios, and you can practice on your own. Okay. The answer is here, but I won't give you now, okay? So epidural, let's go to epidural. Epidural involves the administration of local anesthetic agent into the epidural space, leading to a segmental sensory and motor blockade. The advantage is that you can give a single shot injection, or you can use a continuous infusion via catheter. All right, so this is a slide containing comparing epidural and spinal anesthesia, okay? So let's look at the epidural space. It actually extends from the base of the skull to the sacral hiatus, and that's why I told you the other time that caudal block is a form of epidural block. Okay, boundaries of the epidural space from the arterial, we have the posterior longitudinal ligament, we have the ligamentum flavum posteriorly, and laterally we have the intervertebral foramina. Superior at the base of the skull, we have the foramen magnum, and at the sacral hiatus covered inferiorly by sacrococcygeal membrane. All right, contents include fats and connective tissue. We have the Bastin's venous plexus, which is prone to engorgement in pregnancy, and that should be taken care of when we're doing epidural in a pregnant patient. All right, and spinal nerve roots, which are the target for your LA. So what are the different, what are the equipment needed? We need a Tuohy needle, all right, or other needles we're going to see. You have your loss of resistance syringe, which can either contain air or saline, and each of them has advantages and disadvantages. We have epidural catheter, which can be useful for continuous infusion, for prolonged surgical procedures, sterile prep, and drapes. Okay, so there are 3 different types of epidural needle. Okay, they are here. The Tuohy needle is the popular one, all right, and it allows for insertion of epidural catheter. We have the Crawford and the Husted, okay, needles. Okay, the Tuohy needle has what we call the Caudal tip, all right, which helps to push dural matter away after passing the ligamental flavum instead of penetrating it. The other ones have straight needles without a curved tip, all right, and they have higher incidences of dural puncture. But the advantage is that it is easier to insert an epidural catheter through them. The Husted is intermediate between the Tuohy and the Crawford designs. Okay, so I like to ask medical students these questions. What are the differences between spinal and epidural anesthesia? And these are some of the differences there. Epidural has a wider range of applications than spinal anesthesia. It can be performed at different levels, both cervical, thoracic, lumbar, and sacral levels. All right, epidural can be used for post-operative analgesia, obstructive analgesia, and all of you. And epidural may be done as a single shot technique or with a catheter for continuous infusion. Okay, and we can have what they call walking epidural. I hope we get there before our time. All right, different levels of motor blockage. And the epidural block is less predictable than spinal block. So how do you perform an epidural? You want to see the patient appropriately, sit on lateral decubitus position, just like spinal, and you want to identify your landmarks. Then you insert your Tuohy needle in the midline. There are different ways to confirm correct placement. Number one is the loss of resistance technique. All right, you use your loss of resistance needle and you attach the syringe either with air or saline. Saline is preferable. And as you advance the needle gently into the epidural space, you apply gentle pressure. And once you enter into the epidural space, you'll feel that loss of resistance that shows you that you are in the epidural space. So it's at this time you insert your catheter about 3 to 5 centimeters into that space. Okay, so we have other ways. We have the hanging drop technique, all right? And for me, I like to do the 2 of them, okay? Both loss of resistance and the hanging drop. In hanging drop, you place a drop of saline at the hub of your epidural needle. And as the needle enters the negative pressure epidural space, that drop is softened, although less commonly used, but still valuable in specific settings. For me, because the epidural needle, the loss of resistance needle can be a little tricky, all right, but in trained hands, you may almost get it. But I always want to use both loss of resistance technique and the hanging drop. All right, then you have the test dose. Okay, the reason for test dose, you do not want to give that high volumes of local anesthetic agent meant for epidural space into the subarachnoid space. So you want to test before you give your full dose. All right, so normally the test dose consists of local anesthetic agent like cocaine and adrenaline. Okay, This is when they look at the anesthetic agent like Docaine, for instance, is to detect intratracheal placement, all right, because of the rapid onset of spinal block, and the patient will not be able to move the limbs, all right? And then you want to give epinephrine, all right, like 2 to 3 minutes to detect intravascular placement. And if it's in the intravascular space, you expect tachycardia with a heart rate of 20 or above beats per minute within the first 30 to 60 seconds. Okay, so after you have confirmed your correct placement, you are not in the intrathecal space, you are not in the subarachnoid space, intravascular space, you can give your full dose of your epidural. Now, remember that there are some special considerations that may make your test dose not very accurate. So if the patient is on beta blocker, you may not observe the tachycardia that normally comes with intravascular placement of your injection. Pregnant patients may have an increased baseline heart rate, which can lead to a false positive response. Patients, neonates and elderly patients may not exhibit a strong heart rate response to epinephrine. And patients under general anesthesia, sometimes we combine epidural with general anesthesia, they may not show heart rate changes, all right, which makes adrenaline test dose ineffective. All right, these are some of the complications. Let's just look at some of them. The postural puncture headache, which is very common. It's a positional headache that occurs after accidental or unintentional dural puncture, leading to CSF leakage and intracranial hypotension. All right, this headache typically worsens when sitting or standing and improves when the patient lies down. Oftentimes, after epidural, we ask our patient to lie down for some few minutes or for some time before they ambulate. And how does it happen? So the accidental or intentional dural puncture leads to CSF leakage. All right, this decreases intracranial CSF volume. And what we have is the compensatory vasodilatation, okay, to maintain intracranial hypertension, intracranial pressure, and this will cause headache. Intracranial hypertension also results from stretching of meninges and the pain sensitive structures following these mechanisms. All right, so what are the risk factors? We have the patient-related, we have procedure-related, and we have the perioperative related. So younger patients are at higher risk because they have higher CSF production and lower compliance of intracranial compensation mechanisms. The female gender, especially pregnant women, at higher risk due to hormonal vascular factors. Patients with low BMI, especially with high incidence, all right, possibly due to reduced epidural fat. Pregnant patients with increased intra-abdominal pressure, and patients with previous history of postural puncture headache are most likely to have a recurrence if there's accidental dural puncture. All right, the size of the needle, larger needles create a more bigger dural defect, which leads to increasing CSF. All right, so we have very small needles, 27 Quincke needles, and that's to reduce the risk of postural puncture headache. The needle type also has a role to play. So we're looking at needle size, needle type. All right, the Quincke needles usually with higher PDPH, all right, because they slice through the dura. And that's why most times we use the pencil point spinal needle. Orientation of your needle. Perpendicular insertion to dural fibers increases the risk. While when you place the epidural needle parallel to the longitudinal dural fibers, there's less trauma and lower incidence of PDPH. Multiple attempts at dural puncture increases trauma to the dura, worsening CSF leakage. The higher the level of the puncture, the higher the risk of postural puncture headache because of increased CSF dynamics at higher spinal levels or epidural levels. So perioperative factors, volume of CSF leakage, the greater the CSF loss, the more likely intracranial hypertension will occur, triggering postural puncture headache. Inadequate hydration. All right, this exacerbates CSF volume depletion, increasing the severity of postural puncture headache. And failure to use an epidural catheter. All right, in cases of accidental dural puncture, threading an epidural catheter into the intrathecal space may reduce postural puncture headache incidence because it tends to maintain CSF volume dynamics. So all of these, I've put them into mnemonics, PDPH risk. So pregnancy, dural puncture, previous PDPH hydration status, repeated attempts, instrumentation, the female sex, and the low BMI. So what are the clinical features of postural puncture headache? The onset is about 24 to 48 hours post-dural puncture. All right. Usually the location is frontal and occipital headache, which worsens with upright posture. Okay, it may be associated with neck stiffness, nausea, vomiting, photophobia, tinnitus, and dizziness. Okay, so consider PDPH when you're talking about this, all right, the symptoms, and you have your mnemonics there. How do you manage it? Conservative, first and foremost. Bed rest, and allow the patient to lie supine for some time. All right, those days, I don't know what they do now. We used to say 12 to 24 hours, patient lies on bed, okay? We give caffeine and fluid therapy, okay? Simple analgesics can also help in conservative management. But if this fails, or if the postural puncture headache is severe, we do what they know as the epidural blood patch, which is the gold standard, and you inject about 15 to 20 ml of patient's blood into the epidural space. The idea is when the blood clots, it causes a seal on the dura and preventing further CSF loss. We have the sphenopalatine ganglion block, which is an emerging alternative. And for patients with refractory cases, steroids like hydrocortisone and theophylline may be used. Okay, so this is also to help in management. PDPH, position the patient, encourage supine positioning to reduce and relieve symptoms, drugs, IV fluid, caffeine, NSAIDs, and opioids for pain relief, procedure epidural blood patch, and hydration, high caffeine intake. Okay, so how do you perform an epidural blood patch? Okay, it's a procedure in which a small volume, about 15 to 20 ml of autologous blood is injected into the epidural space to seal off the dural puncture. All right, and the indications is what we provided here. Okay, the same thing of how to get into your epidural space. You collect 10 to 20 ml of the patient's own blood, which is collected under aseptic technique, and you slowly inject it, okay, on the patient feels back pain or pressure. So you give about 1 to 2 ml per second. Total volume injected is 15 to 20 ml. So how does epidural blood patch helps with postural puncture headache? It's been hypothesized that it gives a tamponade effect. The injected blood forms a clot over the dural tear, preventing further CSF loss. All right, it's been hypothesized too that volume increase in epidural pressure, restoring CSF dynamics, will reduce headaches. So after your EBP, you want to lie the patient for 1 to 2 hours to enhance clot formation. You want to monitor for complications. And it's been said that it's about 70 to 90% effective. You may repeat your EBP if the symptoms persist. Okay, this is a great scenario. We may not have time walking epidural. We may not have time to. So let's go to Caudal block. We have the 5 minutes more. Caudal block, all right. So this is when a local anesthetic agent is injected into the sacral epidural space via the sacral hiatus. All right, and because of time, let's look at it. Okay, so this is the sacral hiatus. Be able to recognize it. It's due to failure of fusion of the fifth sacral vertebrae and the fourth coccygeal vertebrae. So it causes an opening here, okay, which leads straight into the epidural space. All right, the sacral corner surrounds it, okay, and this is what you feel when you are palpating for the sacral hiatus. The apex of the hiatus is up here, okay, and this is what you do. Sometimes you put your needle and you feel the lateral, borders of the hiatus, all right, before you inject. Okay, the sacrococcygeal ligament usually or membrane covers this hiatus, and that is what you need to pierce, all right, and you feel a pop or a give that will ensure that you're already in the sacral hiatus. Know that the sacral hiatus is wider and more accessible in children. It's more vascular also, increasing systemic absorption. All right, and caudal block usually performed in pediatrics. It may be done in some adults, especially when you're giving steroids for back pain, but it's more challenging. Okay, so how do you do epidural? The patient may be in lateral decubitus with the knees to the chest, especially in pediatrics. You want to identify the sacral hiatus by palpating the sacral corner on both sides and disinfecting the area. Okay, use a 22 or 25 gauge needle to puncture the sacrococcygeal ligament at 45 degrees, and you advance the needle to the sacral canal until you feel a pop. All right, you want to aspirate to check for blood or CSF. All right, so negative aspiration confirms correct placement, and you inject your local anesthetic agent slowly, watching for resistance or signs of subcutaneous injection. All right, that's what we call now the wash test, all right, with an injection of 2 ml of air, and you're squatted over the lumbar spine, all right? But it's been said not to be recommended because it increases the risk of ear embolism. Then we have the Armitage regimen. That's what we use to calculate what we did earlier on. Okay, the Armitage regimen, it's a standard guideline to determine the volume of local anesthetic agent to be given. So it's categorized, Armitage categorized the dose into 3 levels based on the desired extent of the block. So if you are doing a sacral block, you want to give 0.5 ml per kg. All right, low thoracic, you want to give 1 ml per kg, okay, and the mid thoracic, you can give up to 1.25 ml per kg. All right, so this is used to calculate the volume of local anesthetic agent to be given. Caudal block is not without complications. So cardiovascular depression with hypotension, you can have antisacral injection with perforation of the rectum. It can lead to urinary retention, delayed respiratory depression. You can have accidental subdural intravascular intraosseous injection. Patients may have local anesthetic toxicity. And we have all this like infection, injury to nerves, and all that. Okay, so the new one, we may not be able to go far because of time. The ultrasound-guided neuraxial anesthesia is an evolving technique, especially for regional anesthetic specialists. Okay, it ensures safety, accuracy, and effectiveness of regional blocks. Okay, it avoids real-time visualization of relevant anatomical structures and enhances precise needle placement. Time is up. I think we should stop here today. Okay. Do you have any question, any contributions? Let me stop the, okay. Any questions, any contributions, or anybody wants to attempt